Assalamu alaikum warahmatullahi wabarakatuh. Thank you very much for having me here. It is a great honor for me to be invited in this very educational meeting in Dhaka, Bangladesh. Thank you very much to Prof. Mir Jamal and all the colleagues here. I'm going to talk distal radial access tips and tricks. This is my hospital. Is about 4,000 kilometers from Dhaka. This is Indonesia. And Indonesia have 17,000 islands, five of them the biggest island. Java is the island that I live in. This is the hospital which I work. So this are outlined. As we understand that there are pioneers who doing the distal radial access. First, Dr. Babunasvili and Dr. Dundua from Russia, who did distal radial access for opening radial artery occlusions. Then Dr. Kaladin published a large series of distal radial access. Actually, Dr. Ferdinand Kimenich admitted that he learned from Dr. Rohani from Iran during his visit to Isfahan, which Dr. Rohani explored many distal radial access. And then Dr. Kimenich started to publish left distal radial access in the anatomical snuff box for interventional therapy that's gaining popularity until now. There are some potential benefit of distal radial access, which is first favorable ergonomic and fewer complications, and lower rate of forearm radial occlusions and rapid hemostasis. Also, it is easier access in patients with limited arm motions. Where is actually the access point of distal radial? There are two access points. First is the anatomical snuff box, which are frequently used, and the second one is at the dorsum of the hand, the first intermediate space. So we actually, most of the time, we perform access point from anatomical snuff box because the dorsum of the hand access point is quite challenging. This anatomical snuff box, the snuff box is triangularly depression space on the dorsal aspect of the hand. It has borders, medial border tendon of extensor pollicis longus, lateral borders, there are tendons of abductor pollicis longus and extensor pollicis brevis. And there is proximal border, which is a styloid process of the radius. The roof of the anatomical snuff box is skin and superficial fascia, which is there is cephalic vein and some nerve. And the floor is a bone basement. Distal radius, scaphoid, trapezium, and the first intercarpal. How about the distal radial access technique? First, we have to position the arm in optimally. At the right side, when you are using distal radial access from the right side, patient upper limb is placed on the natural side of the trunk. But at the left side access, the left hand is bent over toward patient groin with the dorsum hand is facing up like this. Grab the thumb under the other forefinger on or hold a roll of gauze. How to identify the access point of distal radial access? You can use USG guided puncture with a luxury in some center and a tactile guided puncture. Most of the time we use a tactile guided puncture only when we are using a 7 French seat. We use ultrasonography guide puncture to measure the diameter of distal radial. And this is the puncture. First, use a anterior wall puncture. Because if you are using true and true puncture, it potentially hit the bone below the radial artery, the distal radial artery. Use 20 open needle directed to the point of the strongest pulse. And seat insertion. We have to use to incise quite deeper skin because of the dorsal side of the hand is tougher. Do not forcibly in inserting the seat. Insert the dilator first before inserting the whole assembly. Sometimes a damage tip of the introducer or seat damage the small artery and risk of occlusion and bleeding. I show you what we are doing. This is we puncture that and insert the wire seat. And then afterward, we inside small skin, small deeper skin incision. And then afterward, look at what we are doing is introduce the dilator first. So when we have no any resistance, we insert the whole system. So that's the way we are doing the puncture and seat insertion. How about when the regular wire seat couldn't pass? So this is the case when we unable to insert the seat wire, the usual seat wire, trying to insert it, but fail. So then we use a PTC wire. Just look at, we are went down a bit the needle. So hopefully there's going to be a bit of parallel with the lumen of the radial. This is a radial. Of course, sometimes we have some kind of problem, but don't stop it. Using PTC wire, so this is the PTC wire can deliver there, and then we can use deliver the catheter. Sometimes we had a loop, have to navigate the loop. Look at it, the left distal radial. It was said that distal radial less tortuous compared with the radial, right radial, but we were facing some of the tortuosity and the loop like this. So just put the PTC wire, and then afterward, starting, grab the hand and then pull out a bit of the whole assembly so it can be Yeah. Okay, that's the problem in a loop navigation. How about the potential limitation of distal radial access? First, there is a small vessel, is a longer access, and length time of catheter for tall patients is not sufficient to the regular using regular wire, because there is a distance about 4 to 8 centimeter distance from the puncture point to the proximal. And there are some tortuosity of brachiocephalic subclavian artery. And of course, there is still paucity data of using distal radial access. Distal radial artery size, actually the diameter is smaller than the forearm artery. The ratio is 0.8 and 0.9. But size doesn't matter. We can use 7 French glide sheet. Its outer diameter was comparable to that of conventional 6 French. Large guiding catheter give a good support and enough space to accommodate multiple devices and other operations. This is the case that we are doing. This is of 64 years old male, hypertension, planned to left main PCI. He had a primary PCI before at high obtuse marginal 5 months ago. Normal RCA, preserved LVEF. As you can appreciate here, there is a severe stenosis at the distal of the left main. And the IFUS finding from the LML LED pullbacks showed there is less than 4 millimeters square. This is the ostial of the ostial of the circumflex looks less disease and quite big lumen. So we decided to do professional stenting, but we do understand there is a calcified lesion at the distal of the left main. So we use 7 French. Sorry, you use a 2 millimeter burr with 170 millimeter RPM, and then afterward guide after pre-dilatation, we facilitate delivery 3.5 38 DS using guide extension catheter, and then we finally using POT using 4.5 15 NC balloon. This is the final port. So looks acceptable. And the IFUS finding very good in terms of left stent area and oppositions, and there is no dissection. And Foreman follow-up showed the flow is good and the lumen still pattern. Successful rate is quite huge in all over the study from distal radial access. So don't be afraid to use distal radial access. How about the pattern hemostasis? Pattern hemostasis imply applying just enough pressure to prevent bleeding through the vascular puncture, but not so much as to cause complete collapse of the vessel under pressure. So producing cessation of flow distally. So this is, we would like to have the hemostasis which have no complication, but the flow still there. The beauty of distal radial access is the Strasbourg access point are directly over the bone, which is the scaphoid bone, which provides support behind the vessel during compression. So it's affect efficacy and safety of hemostasis after distal radial access. Compared with the conventional radial access, proximal radial access, which lay more parallel along the radius bone at the wrist. So this is some of variety of the hemostatic method. You can use elastic hemostatic bandage, classical radial compression device, adhesive hemostatic pressure pad, or using a dedicated distal radial hemostasis. The third take-home message is distal radial artery is the alternative access for cardiac intervention. We should understand the basic principle of obtaining distal radial access would accelerate the learning curve. Of course, we still more data to establish distal radial access as the default access strategy. Thank you very much.